Hi, everyone. Welcome to the Pathology Report. This is a podcast from RCPA. I'm your host, Pranav Dorwal, and it's an honor for me to have Professor Wendy Cooper, who's our guest here. So I'll just introduce Professor Cooper. She's a senior staff specialist at tissue pathology and diagnostic oncology lab at Royal Prince Alfred Hospital in Sydney. She's also an AP clinical stream lead for New South Wales Health Pathology and a clinical professor at University of Sydney. She graduated with honors from the University of Sydney, and after that attained FRCPA and PhD, where she worked on molecular markers in lung cancer. She was awarded the prestigious Peter Bancroft Prize for her PhD. She has more than 200 publications and more than 8,000 citations to her credit. So it's an honor for me to interview you, Professor Cooper, and welcome to the podcast.
Thank you. I'm delighted to be here.
Okay. So the theme of the podcast is that because recently RCPA have released these evidence-based best practice recommendations for molecular testing in lung cancer in collaboration with TOGA, Thoracic Oncology Group Australasia. So I'm going to ask you some questions regarding that so that our audience can get some clarity. So why do you think it was necessary to create these guidelines?
Yeah, we'd been thinking about this for some time. Amongst people who are interested in lung cancer, we realised that we didn't have any recommendations for standardised practice in Australia, and people would ask us, well, what's your approach? And we'd say, well, there's US guidelines we could follow, but we didn't really have our own local guidelines, and we're aware that there's some discrepancies in the way people would go about molecular testing. People would do different tests at different times, and it means that some patients could miss out on optimal care, and oncologists would come to us and say, well, why don't we have our own recommendations for molecular testing in lung cancer? So with the help of Trish Leon, we managed to get funding to do this project, and I was very honoured and delighted to that the college gave me the responsibility to take this on and lead this project, which I think is really important.
Yeah. And because it was two organization kind of guidelines, so RCPA worked with TOGA, and obviously you were the chair of that advisory committee. So how was the experience working with TOGA?
Yeah, look, we thought from the beginning that it was really important that we include oncologists, because the reason we're doing the molecular testing isn't for academic interest. It's not for diagnostic purposes. It's mostly for predictive purposes to help determine what the best treatment is for patients. And we're not experts in what the best treatment is. The oncologists are. So we realise it's crucial that we include oncologists in this, and the Thoracic Oncology Group of Australasia, TOGA, was the preeminent body, and so we approached them and asked if they'd be happy to join us, and they were, and so we were delighted to have their expertise in there. It was a really good group.
Okay. And what were the major challenges that you faced while getting to a consensus? Because it was a big group, I'm sure there must have been varying opinions.
Yeah, look, one of the challenges is everyone's a lot of busy people, getting them all together in one room. Once you get everyone together in one room, all available at one time and all focused on the topic, then we were able to have really, really good, robust discussion. We had the draft key questions and drafted some responses, and everyone was very generally on board with what the draft recommendations initially were, but we really did thrash out some of the precise wording for some of those questions just to make sure that we got it right. It did take a little bit of time, but in fact, all of the recommendations were unanimous, right, apart from one. Okay. And we still reached consensus. So we set our the benchmark for consensus to be that at least 80% of us needed to agree to have consensus. All of them were unanimous apart from one, and that was a recommendation on reflex testing.
Right.
So everyone agreed that reflex testing should be undertaken in advanced stage non-small cell lung cancer, non-squamous non-small cell lung cancer. But where there wasn't 100% unanimous agreement was what you do, and it's not uncommon, where you don't know the stage of the patient's lung cancer. Do you not test and wait for a request, or do you just go ahead and test? And there was, we did discuss this quite a bit, but we got consensus 80% saying that we should still test on reflex if you don't know the stage of the patient's disease. Give the patient the benefit of the doubt, get those results through so that decision-making isn't delayed.
Sure.
Yeah.
And now that you've touched on the stage, so what do you think is the role of these guidelines in early stage lung cancers?
Yes, I think, mostly, pathologists are pretty familiar with that you need to do testing in advanced stage disease, because we've been doing that for, quite a long time now, even though the number of biomarkers has increased. But what I've found is that there's perhaps not so much familiarity with the need to do testing in early stage lung cancer now as well. And that's because there's some really effective treatments in the adjuvant setting, so post-operative, immediately following curative resection, or in the neoadjuvant setting, so treating before curative intent surgery. And so we do need to do some biomarker testing in early stage disease, stage 1B and above, and that's for EGFR, ALK, ROS, and PD-L1 are the 4 that are needed at that time. A lot of places still just do the full, probably at your lab,
yes.
do the full range of testing.
Full range, yes.
Yeah, and sometimes it's just as convenient just to do the full range even in early stage rather than have a different panel.
That's right.
But the bare minimum needs to be EGFR, ALK, ROS, PD-L1.
Okay. And out of those, I'll pick 2 markers which are quite commonly discussed, especially because traditionally we have been doing IHC and FISH testing for ALK and ROS1. And a lot of the newer assays have got those markers included, especially in the RNA component for ALK and ROS1 rearrangement. So what are your thoughts and what do the guidelines suggest in that case?
Yeah, so we recommended that for ALK and ROS and all of the other fusion ones, so RET and NTRK as well, that RNA-based NGS testing is the ideal method to identify these biomarkers. Not everyone has RNA NGS available. It is becoming more widely available. So if you don't have it available, you certainly can still do IHC and FISH, and the Medicare reimbursement is still available for those. But our recommendation is for NGS, you get the results faster, they're more comprehensive, you find the fusion partner. There's a whole lot of reasons to make it more efficient and reliable. I guess as you said, people ask about the IHC when everyone was doing IHC and FISH, you could only do FISH, or you only reimbursed for doing FISH if the IHC was positive. So do we still need to do IHC? And you don't have to do it if you're doing the RNA fusion testing. It's certainly not needed.
Right.
But the recommendation was, it was interesting, it mostly came from the oncologist, that the ALK IHC is something still really valuable to them. And that's just because it is so strongly predictive of having an ALK fusion, and you get results so quickly that they'd like to know rather than wait for the fusion result.
Right.
Whereas the ROS1 IHC, as I'm sure you know, and have had experience, it's not quite so reliable or sensitive. So it's not so specific, I should say, and so no need to do the ROS1 IHC if you're doing the RNA fusion testing and no longer using FISH.
Sure. And a lot of my colleagues and myself, we always had clarity about the non-squamous non-small cell lung cancer. But when it comes to squamous cell carcinoma, so I see that the guidelines talk about that as well. So can you please shed some light on that?
Yeah. So I think everyone's familiar with that, the full comprehensive range of biomarker testing gets done for non-squamous non-small cell in the advanced stage. But for pure squamous cell carcinoma, the only ones that we're required to do, that we recommend to do, is the MET exon 14 skipping alteration testing for that, and PD-L1 IHC, and that is because, as you know, like the other, the chances of having the other alterations are very negligible in a pure squamous cell carcinoma, and the only one important exception is if you have a surprising diagnosis of a squamous cell carcinoma in a small biopsy. I don't know if have you ever had that? Have you ever come across it?
Yes, we have seen sometimes EGFR mutations because and the hypothesis we say is that because there might be an adeno component, it might be an adenosquamous rather than a pure squamous.
That's right. So if they're and did you know that they were a non-smoker or anything like that? Did you get any information?
Yeah, sometimes we discuss when you get surprising results.
Yeah. So if it's a a diagnosis of squamous cell carcinoma on a small biopsy or cytology specimen, and the patient's a non-smoker or very light smoker, or they're a young patient, then they may well harbour one of those targetable alterations, and so then the full range of biomarker testing is warranted. We don't need to do that on reflex because we often won't know that in clinical information. It's the onus is on the oncologist in that setting to request that. Yeah, and I should mention we don't really go into what's reimbursed in the recommendations because that may well change and so on. But it's worth knowing that I'm sure you're familiar with the MBS reimbursement for the DNA and RNA panel testing doesn't specify whether the tumour is squamous or non-squamous. It just says non-small cell. So we can still utilise that Medicare item number, which makes our lives so much easier.
Yeah. Okay. Thank you so much. Another topic which is being talked about quite a lot, especially in our conversations with oncologists, is about the ctDNA testing. So what do you think about that? Like, what are thoughts on ctDNA testing? Is it still standard of care? Like, how far is it away from being a standard of care?
Yeah, look, it's one of those things, and we were just chatting about this beforehand, is that, the technology's been around for a long time, but sometimes if there's no reimbursement mechanism in place, then there's not going to be much uptake. But I think there really is still clinical value for liquid biopsy, ctDNA testing, and that's when we look for the molecular variants in DNA that's shed into the bloodstream, so in plasma samples. And in our recommendations, we certainly have addressed liquid biopsies, and we've said that it can be considered. So we haven't said should. We haven't made it a mandatory recommendation, but should be considered in the setting of where there's not enough tissue in a biopsy sample, or it's inadequate, or it's failed, or something like that. Rather than put the patient through a repeat biopsy, consider trying it on the blood test to save them a high risk or potentially high risk tissue biopsy. And the other setting where it can be considered is if there's a real clinical urgency for the results, because obviously you can get a blood test to the lab quicker, if than a tissue one where you've got all the process and the diagnosis and so on. And that's in the setting of advanced stage disease where they're looking to treat up front with a biomarker selected treatment. And the other setting is when oncologists sometimes want to know if there's a resistance mechanism following when someone has been on a targeted therapy. So again, liquid biopsy can be considered. This is what we've said in the recommendations. When someone's looking for a resistance mutation, if the tissue is inadequate or it's too high risk to get a repeat biopsy. Yeah. Do you use it at all in your setting?
No, not with us. We're thinking about it, but we haven't started using it.
Yeah.
He said.
Do you think there'd be a lot of uptake if
there
was reimbursement?
Yeah, I think so.
I
the
think so
oncologists
too.
are just waiting for it, so to get into it. And as the markers are coming thick and fast. Like, we have more and more markers and more targets and target therapies being available at a faster rate than ever in the history.
Yeah.
So how often do you think these guidelines would need revision?
Yeah, well, we've, that's an important thing because it's all very, well and good to put out recommendations, but they can quickly become out of date. And so we've set a time limit of 2 years that they need to be revised. And so that's on us to reconvene at 2 years and do that. And we put in the caveat, unless there was some significant data change that emerged in that period that we really needed to address something. So we could reconvene earlier if need be.
Okay, thank you so much, Dr. Cooper, for your time and being here for the podcast. And I'm sure it was very useful for our listeners, and they'll gain a lot from listening to these guideline recommendations that you have put out. And for our audience, we'd like to say that these guidelines are available on the RCPA website, and they have been recently published a week back in the RCPA journal. It's an open access article, so you can go through it if you are working in this area. Thank you so much for Cooper.
Thank you. Pleasure.